Hello? Hello? Can you hear me? Can you hear me? No?
Uh, Good afternoon,
How are you
Pep.
doing?
How are you?
Good, how are you?
Uh, I am fine.
We start in 10 minutes.
Okay.
Uh,
Okay. Today, the speaker from USA and Athens.
you want, someone needs to come in?
Uh, uh, Today, the speakers, Prof. Michelle Shoulder from USA and Prof. Aristoteles Kalifas uh, from Athens.
Oh, can you write that? Can you text that, please? Can you text, please?
Okay, okay,
My hearing is bad. My ears are bad.
okay. Mm.
Okay, Michael from New York, okay?
Okay.
Can he come? Is he coming?
Oh, yes.
Oh, he's in the panel?
Oh, yes.
Oh, he's not in the panel now. Uh, okay. What what about Michael?
Uh, he will join after 7 minutes.
Oh, okay. Okay.
Hi John, how are you?
Good. How you doing?
I'm doing very well.
How you been? You been busy?
Me? Yeah. I'm busy, and a few minutes later I will be busy. So I try to be here as early as possible. I mean,
Right.
there there is a lot of things that I have to do.
Okay.
John Bennett.
You know, I'm starting a group now in India for students, for med students and residents.
Uh, John Bennett. Mac and اسمي happy list.
Can you see the panelists now? Okay. Okay. I see Nethmini, right?
Ah,
Yes.
yes.
Yeah, I got her. She's coming in.
Make her happy list.
I'll let the other ones in too. I don't know who they are, but Nadia, Ahmed. Okay. Hello, Nethmini. I'm Dr. Bennett.
Hello,
Welcome.
how are you? Thank you.
I'm fine.
So it's a new member. Nethmini is a new panelist. This is the first one, Nethmini?
Yes, it is. I'm very happy to be here.
Are you scared?
A bit. I don't actually know what to expect.
Well,
But yeah.
let's explain it. I don't know what Abdel wants you to do. I'm gonna who should I introduce first, Ahmed? Should I introduce Nithmini or introduce you, Ahmed, or who?
Look, I think we should I mean distribute our roles. One should start, for example, as introduction.
So you don't want me to start with you? Let me start
Yeah,
with you. Let me start with you, and you run the show.
okay.
Or you can't stay the whole time. You have to go.
Yeah. I'm going to start. Then we will go forward. I mean, both Abdurrahman and Mr. Mini.
Okay, I'll introduce you, and you determine what you want to do.
Yeah. Okay.
Okay.
Okay. John Bennett.
Okay, Anthony, Eris Harold's here.
Aristoteles make his happy list.
Okay, he's coming in. Eris.
Hello, can you hear me and see me?
Yeah, hi. Greetings.
Good afternoon.
Good afternoon to you too. It's 3 o'clock there, right?
Yeah, we started in about 5 minutes. Dr. Kalivas, you're from Athens, correct?
Yep, I'm from Athens. That's right. I'm
My
here at the
favorite city in the
University
world. It's my favorite city in the world.
Athens.
Yes.
You like it? It's
Oh,
a
I
bit of a
love it.
jungle. It's a
I
bit of a
love the
jungle,
view.
but I like it.
I love Greek mythology.
Yeah, that's right. Where are you from?
I'm from originally Boston, but now in Miami.
Of course, yeah.
I went there.
You prefer Miami to Boston?
No, Miami. I never want to leave here. I mean, living wise, but I loved Athens. I loved the islands, the museums. I want to go back and spend more time. 3
You
days.
should.
3 days is not enough in Athens.
No, for sure. 3 days you can see the main touristic points. You can see the old city, the ancient city, Athens, like Acropolis and things like that. But yeah, I agree, not enough, not enough. I was in Toronto for 7 years. I just came back.
Toronto?
Yeah, I was in Toronto. I did my fellowship there with
St.
friends from
Michael's,
TUE.
St. Michael's.
The UHN, the University Health Network, Zade and Gentili and Michael Fellings and Andres Lozano and Paul Conca, Mark Bernstein, all the team there.
Okay.
And then I stayed for 4 years. What's that?
John Bennett. John Bennett.
Okay, Michael's here.
Mac
Yeah, Michael's here. I see him. I see him. He's coming in.
Hi.
Okay. Hi, Dr.
Hello.
Fuller. Sean Bennett from Miami. And you met Abdel. Abdel, he's a co-host from Yemen. and Nethmeni, she's also, are you a student, Nethmeni?
Yes, I am. I'm actually from Armenia.
Okay, welcome. That's
Nice.
Michael Shoulder. And Michael, you're from New York, or you're from New York, correct?
Yes, yes,
Okay, the Zucker School of Medicine and on
That's
the
right.
island, right? That's on the island, right?
right, right.
Right.
Okay. Everyone's here. Okay, Ahmed, are you there?
Okay.
Ahmed?
Okay.
Yes, I'm
Oh,
here.
hold on,
I'm
hold
just
on. Okay, we're gonna start in a minute, okay?
Okay.
sure.
Start.
Everybody's ready?
Yes. We are ready.
Okay, good. Okay, just a minute. We'll do it just like Hollywood Aristotle.
What's that? Are you photo?
Okay. We start exactly on time. We're as punctual as German trains. Okay, 10, 9, 8, 7, 6, 5, 4, 3. Good morning from Miami Beach. This is Dr. John Bennett, broadcasting for Neurosurgical TV. We have this week the Walter Dandy Neurosurgical Societies of both Armenia and Yemen combining forces to present this webcast. I'm going to introduce right away the head of the Walter Dandy in Yemen, Ahmed Al Ghanemi, and he's basically going to run the show. Good day, Ahmed.
Hi, dear John. Good day, you and all the attendees. First of all, let me introduce myself. Here's Ahmed Al Ghanmi, the Special Assistant to the Global President of Walter E. Dandy Neurosurgical Society, and also the President of Dandy Club of Yemen. Actually, it's my honor and privilege to host these esteemed and distinguished professors from US and from Athens. So now let me introduce Professor Michael Shoulder. Professor Michael Shoulder is a chairman and residency program director of the neurosurgery in Donald and Barbara Zucker School of Medicine in the United States. So it's yours, Professor.
Thanks, Dr. Al-Khanemi. I will say that this topic is a real one, pachymeningitis, and it's a good subject for neurosurgeons to know about because it's a real thing, and I've encountered it myself certainly early on in my career when it was less well understood, and it's important to recognize it before embarking on potentially aggressive surgery to avoid harm to patients. And I appreciate the opportunity to be here today.
So who will start the presentation? Your Excellency, I mean Professor Michael, or just?
Well, excuse me?
Is there a presentation with you, sir?
No, I'm just here to moderate, to offer comments and support, etc. I didn't want to take up anyone else's time.
Okay, sure. So, Mithmini or Abdurrahman can introduce another speaker.
Hello, so I'm Nethni. I am the president of the Walter Neurosurgical Society in Armenia, and I'm very happy to be here amongst all of you. And it's my honor to, collaborate with Dandy Yemen on this webinar. And I would like to introduce Professor Aristotelis Kalivas, if I'm pronouncing that right.
Correct.
All right, perfect. He is Assistant Professor of Neurosurgery, Surgical Neuro-Oncology, and Skull-Based Surgery in the National and Kapodistrian University of Athens. Would you like to introduce yourself?
Sure. Yeah, I'm Ari Kalivas. First of all, I would like to thank you for the invitation. It's an honor to join this forum, and I would like to congratulate you for all the efforts you've put into this. I see in social media that you're very active, and kudos to you all. As you said, I'm an assistant professor in neurosurgery at the University of Athens. For the last 6-7 years, I was in Toronto. I did my fellowship there first, and then I stayed on as a staff and assistant professor there. And the topic that we're going to talk about today is quite a challenging one. It's a distinct challenge for brain metastasis teams. And the data we'll present will be mainly from a series of papers we've contacted at the University of Toronto, and of course papers from other authors that investigated the theme. If it's okay with everyone, John and the team, I would like to share my screen. Is that okay?
Yes, go ahead. Mhm.
Can you see my screen? The presenter mode, the
Yes.
presentation mode?
Perfect. Perfect.
Okay.
Yeah.
So this is, again, thank you very much. This is the theme of today's talk. A distinct challenge, as I said, pachymeningeal failure as a distinct neurosurgical entity, diagnosis, risks, and outcomes. I would like to start. Sorry, I'm trying to change the slide. Just give me a moment. Yeah, we're good. So I would like to start with the first question, which is, what is pachymeningeal disease? And pachymeningeal disease, or PMD, or pachymeningeal failure, or PMF, these are interchangeable terms, is a recently identified pattern of brain metastasis recurrence. It typically appears as new nodular lesions along the dura, usually after surgical resection of a brain metastasis, followed by adjuvant stereotactic radiosurgery. This type of failure was not commonly identified earlier on, as Dr. Schulder said, when he started to identify these recurrence, this failure maybe was not well known in the literature. That really aligns with the data we have. Before the widespread use of SRS, it is true that we didn't know about this. And for years, these cases may have been misclassified or simply missed. What makes pachymeningeal disease unique is both its radiographic appearance and its biological behavior, which differ significantly from the more well-known leptomeningeal disease. Recognizing the pachymeningeal disease is essential because it has important prognostic and, of course, therapeutic implications. Let's take a step back and try to define the meningeal disease in general, the meningeal recurrence, the meningeal failure. Meningeal disease or failure after brain metastasis treatment is broadly categorized into these two types, okay? Leptomeningeal disease and pachymeningeal disease. Leptomeningeal disease is the classical form we've long known. It involves dissemination of tumor cells within the leptomeninges, the pia and the arachnoid. And typically, it presents, sorry, why I cannot see that. I lost my screen. Can you see my screen still? Can you?
Yeah.
Can you see?
Yeah, we
Okay.
can see.
It now came back. I don't know. It's some glitch with my computer. But as I said, the leptomeningeal disease involves the leptomeninges, which is pia and arachnoid, and typically presents with diffuse linear enhancement along sulci, cranial nerves, or the cerebellar folia. The pachymeningeal disease now is a nodular pattern of recurrence involving the dura mater, what we refer to as pachymeninges. It tends to appear as discrete, extraaxial enhancing nodules, often near the surgical cavity or along the tentorium or convexities. Let's go to the diagnosis. How can we recognize the pachymeningeal disease? Distinguishing pachymeningeal from leptomeningeal is essential and quite feasible when you know what to look for. The Pachymeningeal disease is on the right of the screen, okay? It appears on post-contrast T1 MRI as one or more nodular extraaxial lesions. Can you see my cursor?
I'm sorry.
Yeah. We can see that.
Okay,
Yeah, we can see.
so you can see these nodules here, okay? They are in contact with dura. This is in contact with the convexity dura. This is in contact with the tentorium. They often arise near the surgical site. You can see here is the craniotomy, right? But they can appear remotely as well. This is remotely from the craniotomy. You can see Pachymeningeal disease on the contralateral side as well. They spare the sulci as opposed to the leptomeningeal disease here, right? You see, they spare the sulci and the subarachnoid spaces, and it's not within the field of radiation. It's outside the original SRS field, so it's an out-of-field failure. Leptomeningeal disease in contrast, and you can see on the left, presents with linear enhancement along the leptomeninges, along the sulci. So you might see this sugar coating here of the cerebellar folia, enhancement along cranial nerves, or diffuse sulcal pattern. Here are some additional pictures, and you can see how the sulci enhance in leptomeningeal disease. You can see the sulcus here, all these sulci enhance. Whereas in Pachymeningeal disease, the sulci are spared, you can see here. LMD often results from hematogenous dissemination or CSF seeding. PMD, in contrast, is thought to result from mechanical disruption and local seeding of tumor cells along the dura during the surgical resection. The concept is that limited radiation field of SRS may fail to sterilize the microscopic disease along the dura. In our studies that I'm going to share, we used consensus diagnosis in Toronto during our weekly multidisciplinary conferences. And these distinctions were critical to ensure Pachymeningeal wasn't misclassified as local failure, leptomeningeal, or radionecrosis, which can be the case. Now let's try to answer the question whether Pachymeningeal disease is a neurosurgical entity. This is the first of the series of our studies. I would like to show you, we didn't set out to study Pachymeningeal failure in this paper. Our focus was different. In this study published in Neuro-Oncology, we looked at patients with large brain metastases, 2 centimeter or larger, to see whether outcomes were better with definitive SRS alone or with surgery followed by adjuvant SRS. But as we reviewed the cases in detail, we noticed this subset of patients who had surgery followed by SRS who developed new nodular dural-based lesions near their resection cavity. This didn't fit the criteria of leptomeningeal, neither local recurrence. They were Pachymeningeal disease cases, and we didn't see this pattern in patients who received SRS alone. And you can see that in the first graph I'm showing you here, the probability of Pachymeningeal in patients who received SRS alone is 0. You see here, 0. Whereas it's fairly high in patients who received surgery and SRS. And this is not the case for leptomeningeal disease. You can see it. You have instances, you have incidents, true incidents in both categories. Interestingly, a previous study by the Boston group in Harvard in 2019 in JAMA Oncology had reported something similar. They described Pachymeningeal disease as well as a pattern of dural-based recurrences, often near the surgical site, suggested seeding along the dura, and possibly during surgery, and it clearly supported the same idea as our study, that these lesions don't happen randomly, they're rarely seen in patients treated with SRS alone, and that Pachymeningeal disease is a distinct failure pattern tied to neurosurgical resection. So indeed, it is a neurosurgical entity. But this doesn't mean surgery leads to worse outcomes. I don't want to get misinterpreted. In fact, our data show the opposite. Again, in this study, which included 364 patients with large brain metastases, we compared overall survival between surgery plus adjuvant SRS and those treated with definitive SRS alone, using both univariate and multivariate analysis and also propensity score matched analysis to balance key variables. We found that definitive SRS alone was consistently associated with worse overall survival. So even though Pachymeningeal disease was more common in the surgical group, 16 versus 0% at 12 months, the overall survival was significantly better in patients who underwent surgery plus SRS. This really underscores two things before we go to the next chapters. One, surgery remains critical for appropriately selected patients. And two, the occurrence of Pachymeningeal disease does not cancel out the survival benefit of resection. It just means that we need to understand and manage this complication better. Now let's try to understand the disease a bit better and try to identify risk factor for developing Pachymeningeal disease. To do that, we conducted a dedicated analysis of 144 patients who had undergone resection, followed by SRS for large brain metastasis at UHN in Toronto. And our goal was to identify clinical, anatomical, and treatment-related variables associated with the development of Pachymeningeal disease. The cumulative incidence of Pachymeningeal disease or failure at 12 and 24 months was 18 and 22%. So you see, it's a real thing. It's a quite big number. We compared the group of patients who developed PND to a control group who did not. This is the univariate analysis, and you can see we examined age, gender, primary, ECOG score, GPA, whether they presented with seizures, if they had neurological symptoms, radiosensitivity, prior surgery, prior radiation therapy. And you can see that female gender, higher GPA score, and no prior radiation were correlated with the occurrence of PMD. Then we examine radiological and anatomical characteristics like suprainfratentorial location, volume, cystic or hemorrhagic appearances, multiplicity, whether they had controlled or uncontrolled extracranial disease, and the distance of the tumor from the pia and dura. And you can see that controlled extracranial disease and contact of the tumor with dura and pia preoperatively correlate with PMD. And finally, treatment-related factors such as an block versus piecemeal resection, which was close to being statistically significant, and we could see that trend, extent of resection, systemic therapy type, and others. In multivariate analysis, we narrowed down the independent risk factors most strongly associated with developing PMD, and three variables stood out. First, pial or dural contact, which was the most significant predictor. Tumors with contact to these surfaces had a 3.5-fold increased risk of PMD. Second, patients who underwent piecemeal resection had more than double the risk compared to those who had an en bloc resection. And third, having controlled extracranial disease was associated with nearly a 4-fold increased risk of PMD. Let's see one by one. Contact with pia or dura. Tumors close to these layers can disseminate directly during surgery, especially when the surgeon must work through narrow sulci or subarachnoid corridors. And this is particularly true for lesions near the falx or tentorium. These are deep line structures and often require piecemeal resection, but are also richly vascularized, which is important. They receive blood from both meningeal and cerebral arteries, forming anastomotic pathways between the dura and the brain. This unique vascular environment might make these areas especially vulnerable to seeding and tumor cell survival, and helping us explain why PMD is so high in lesions in contact with the surfaces. You can see here the green is tumors in contact with Falx tentorium, then pia dura, and then the rest. A clear association between piecemeal resection and increased risk of pachymeningeal failure we've seen. The likely mechanism is intraoperative tumor spillage. When we remove tumor in pieces, especially in tight corridors, cells might be left behind or disseminated into, again, the highly vascularized pachymeninges, which then serve as fertile ground for recurrence. It's important for a surgeon because piecemeal resection is potentially a modifiable risk factor. Whenever feasible, an en bloc resection could be the goal. That said, of course, piecemeal removal is sometimes unavoidable, particularly for very large tumors or when operating near eloquent cortex, where the manipulation of the surrounding tissues must be minimized to preserve function. One of our more interesting findings was that pachymeningeal disease tends to occur in patients with controlled extracranial disease. This contrasts with leptomeningeal failure, which is more often seen in patients with widespread systemic progression. What this suggests is that PMD may reflect a different biological mechanism. Rather than being a marker or disease of or disease aggressiveness, a marker of disease aggressiveness, may be more iatrogenic in patients who live long enough for it to manifest. However, our analysis accounted partly for that by treating death as a competing risk in statistical analysis, and PMD incidence still remained high, which strengthens the argument that there is a real pattern in there and not just a survival artifact. Following our institutional findings, the next logical step was to look at the broader landscape. So we conducted a systematic review of the literature on pachymeningeal disease. We screened almost 600 articles, and we ultimately included 12. And we gathered data on almost 4,000 patients. The mean prevalence of meningeal disease was 20.9%. And when we broke it down, PMD accounted for 54.6% of that. This means that PMD seems to be the more common presentation of meningeal involvement in the setting of an operated brain metastasis. And importantly, since at least a few of these studies that we included include mixed cohorts of both operated and non-operated patients, it's very likely actually that the true prevalence of pachymeningeal disease is even higher. As I mentioned earlier, awareness and recognition of PMD are absolutely essential. And one striking observation from the review is that in earlier studies, the reported prevalence of PMD is lower. However, in more recent years, as center became more familiar with the radiographic features and began to actively look for PMD on MRI, the reported prevalence increased. This likely reflects not a true rise in the incidence of the disease, but rather a better diagnostic awareness of the teams. In this slide, I've listed all the patient, disease, and treatment-related risk factors for PMD that were identified across the studies. You can see patient-related factors, female sex, Karnofsky, high Karnofsky, presence of seizures, whereas disease-related factors, you can see gynecologic or urothelial primary, tumor location, multiplicity, dural pile involvement, control or absent extracranial disease, and others. And treatment-related risk, the main factor was piecemeal versus en bloc resection and prior brain radiotherapy. From the broader set of reported risk factors, 6 were identified in at least 2 studies, and we therefore included them in our meta-analysis. These were infratentorial location, cystic appearance, multiple brain metastases, systemic therapy at the time of surgery, gross total resection, and controlled extracranial disease. And out of these 6, 2 risk factors emerge as statistically significant. One is controlled extracranial disease with a hazard ratio of 3.08, and infratentorial tumor location with a hazard ratio of almost 2. This means that patients with well-controlled systemic disease and those with tumors located in the posterior fossa are at significantly higher risk for PMD. Let's go to the outcomes now. Going back to our institutional pachymeningeal failure study, it showed that it is associated with reduced overall survival, but outcomes are still better than those with leptomeningeal disease. So pachymeningeal increased the risk of death by almost 3, but leptomeningeal carried a much higher risk, more than 10-fold, reflecting its aggressive nature. So this data support that PMF and LMF are distinct entities. PMF or PMD appears more localized and possibly iatrogenic, while the leptomeningeal behaves as a more systematic dissemination of the disease. This is confirmed, and after looking across the broader literature, the results were consistent with our cohort. The mean of median overall survival for patients with PMD was 10.6 months, and for leptomeningeal, it was just 3.7 months. So quite significant difference. Next, regarding the clinical presentation and imaging characteristics, about a third of pachymeningeal disease cases presented with neurological symptoms, while the majority we found incidentally during routine postoperative imaging. In terms of location, about 40% of the craniotomy site, and about at 35.5% involved bilateral convexities, suggesting a more widespread disease. 3 patients, about 10%, had concurrent leptomeningeal, indicating a mixed meningeal failure. This is interesting. We also saw spinal involvement in about 1 out of 5 cases, and notably in the majority of those, 5 out of 6, the intracranial disease extended more than 2 centimeters beyond the surgical margins. And on the treatment side, the majority of patients were treated with whole brain radiation therapy after the diagnosis of PMF, and the rest got either IMRT or SRS. Despite treatment, about 26% of patients went on to develop new sites of PMF or LMF, and re-radiation was sometimes attempted, but outcomes were poor. On this slide, we're looking at survival curves from the time of pachymeningeal diagnosis based on several subgroup analysis. We tried to understand whether specific features of pachymeningeal disease were linked to worse prognosis, including whether the PMF was solitary or multiple, whether the lesion was close to the surgical site within 2 centimeters of the bone flap, and finally, whether there was concurrent spinal involvement. And out of these, only spinal deposits showed a statistically significant association with survival. Patients with spinal involvement in PMD had a higher risk of death with a hazard ratio of 2.76. So maybe spinal imaging in patients diagnosed with PMF is not a bad idea, especially when symptoms are present or disease appears extensive. Let's now focus on a subgroup analysis, examining how dural contouring margins in adjuvant SRS affect the risk of pachymeningeal disease. We looked at patients with tumors located, actually contacting the dura. These were 76. And the dural venous sinuses, these were 38. And these were stratified by the dural margin used in SRS, 1 to 5 millimeter versus 6 to 10. And key findings are the following. In tumors contacting the dura, using a 6 to 10 millimeter margin was associated actually with no pachymeningeal failure, a significant finding. But no such benefit was seen for tumors contacting the dural venous sinuses. Maybe wider dural coverage in high-risk cavity is a good idea then. Well, some guidelines, like the ones from Soliman et al. Here, already suggest 5 to 10 millimeter margins for tumors in contact with dura. Our data also confirm that leaning towards this wider coverage may be protective. Next, what can we do differently or better? As we have already mentioned, the pachymeningeal disease first recognized after SRS became the preferred radiation treatment over the whole brain radiation therapy. And this raised the idea that the change in radiation method might be the reason we started seeing PMF. But it's also likely that many of the pachymeningeal disease cases during the whole brain radiation era were simply missed because we didn't yet know the disease, or we didn't know how to look for it. To explore this, we looked at our prospective database of patients treated with either whole brain radiation or SRS to see if the difference was real. 274 consecutive patients treated with upfront surgery followed by either whole brain radiation therapy or SRS. This is the institutional approach for adjuvant SRS following surgical resection of brain metastases. We shifted from whole brain radiation to adjuvant SRS in 2015, but I don't think I should bore you with the rest. Let me continue to show you the data. In this slide, you can see the incidence of pachymeningeal failure between patients who received SRS and those who received whole brain radiation, and you can see the significant difference with SRS, 18 at 1 year, 23% at 2 years, whereas for whole brain radiation, it remained close to 0, 2%. Of course, this was statistically significant, and as such, it seems that SRS is significantly and truly correlated with pachymeningeal and did not just reveal the pattern. In contrast, you can see leptomeningeal disease was not significantly different between the two groups. Now, what about neoadjuvant SRS as an alternative solution to minimize that complication? This is a prospective multi-center phase 2 trial we conducted with UHN, St. Mike's from Toronto, and Charité from Berlin to evaluate the safety and feasibility of delivering SRS before surgery in patients with large brain metastases. The goal was to see whether preoperative SRS could reduce complications like radiation necrosis and, of course, meningeal dissemination. Patients including those with one large index metastasis requiring resection and up to 9 additional smaller lesions treated with standard SRS. The index lesion received pre-op SRS 14 to 21 gray, followed by surgical resection within 72 hours, and the primary endpoint was 1 year rate of grade 2 and above radiation necrosis at the index site, but also secondary endpoints, survival outcomes, and rates of local and, importantly, meningeal failure. 37 patients enrolled, 35 analyzed. Only 1 case of pachymeningeal disease was observed. A rate of 3.2% at 1 year occurred 11 months following complete resection of a posterior parietal metastasis from a hepatocellular carcinoma. This low incidence is important and noteworthy, especially when compared with historical pachymeningeal disease rates following adjuvant SRS, which, as we saw, can reach up to 34%. So why might neoadjuvant SRS be protective? The idea is that irradiating the intact tumor preoperatively may sterilize viable cells and reduce the risk of tumor cell dissemination during surgical resection. In contrast, adjuvant SRS targets the surgical cavity, which may miss microscopic tumor cells that have already spread intraoperatively, particularly during along dural surfaces. Only one patient developed classic leptomeningeal within 3 months, and this case likely represented pre-existing leptomeningeal disease evident retrospectively on pre-op imaging. This was the primary endpoint of the study, radiation necrosis, and no patient developed grade 2 and above. And these rates are consistent with prior studies and significantly lower than those reported for post-op SRS. The local failure was a problem, though. 6 patients experienced local failure, yielding a 1-year rate of almost 18%. All of them had undergone gross total resection, and this rate is on the higher end compared to prior retrospective neoadjuvant SRS studies and comparable also to historical data from adjuvant SRS. So single fraction neoadjuvant SRS may be safe, but may not provide optimal local control in all cases. And this raises the question now of whether strategies such as fractionation in the neoadjuvant setting, higher doses or larger margins could help improve outcomes. In the same vein, retrospective data suggests that fractionated neoadjuvant SRS achieve local failure rates of 5 to 7.5%, which are quite lower. And this takes me to this last study. This is the largest study to date on neoadjuvant SRS for brain metastasis, the international PROPS-BM trial, retrospective, multi-center involving over 400 patients across 8 institutions, comparing single fraction versus multi-fraction preoperative SRS. The rationale was to test whether fractionated could improve local control, which was the problem we saw with our trial on single fraction SRS, and reduce toxicity, especially in larger lesions. In total, 404 patients, 78.5 single fraction, 21.5 multi-fraction SRS, mostly in 3 fractions. There were baseline differences between the 2 groups, so to minimize confounding, the authors did also a propensity score matched analysis, resulting in a matched cohort of 162 patients, 81 in each group. And with that context in mind, let's now look at the main results. Let's see the unmatched group first. Local recurrence at 2 years was significantly lower in multi-fraction, okay? Radiation, adverse radiation events, slightly higher but not significant. And the composite endpoint, which was local recurrence of the cavity, adverse radiation events, and PMD, Pachymeningeal or nodular MD, was lower with multi-fraction, but not statistically important, and the overall survival was similar. In the matched analysis now, cavity local recurrence failure at 2 years was much lower in the multi-fraction, okay, statistically significant. Meningeal disease remained low and similar, and adverse radiation events were comparable. And this composite endpoint, again, cavity local recurrence, adverse radiation events, and PMD was significantly lower in multi-fraction SRS. And these are the graphs. The first graph shows the lower 2-year local recurrence for multi-fraction SRS, and the second graph, the composite endpoint, and multi-fraction, again, performed better. So it seems we have good local control, toxicity, and Pachymeningeal disease rates with multi-fraction SRS. So to conclude, looking ahead, several priorities are emerging in our efforts to reduce the Pachymeningeal disease risk, optimizing dose and fractionation in adjuvant SRS, exploring and expanding the role of multi-fraction neoadjuvant SRS, Standardizing the classification and reporting of meningeal failures is important, clearly distinguishing between classical LMD and nodular Pachymeningeal disease. And while current findings are promising, larger prospective trials and randomized data are essential, especially to confirm whether multifraction neoadjuvant SRS meaningfully reduces the risks and improves long-term control. And ultimately, the success will probably depend on careful trial design and tailored patient selection. I think that was it. And before I finish, I would like to invite you to join us for our upcoming Neuro Connect course in Toronto this fall. It will be a multi-layered course. It's mainly white matter dissection with cadavers and the Klingler's technique, the real thing, to see the white matter tracts and understand the brain connectivity, to understand how we can improve the ways, the corridors, and the mapping techniques to operate on gliomas and metastases and intraparenchymal lesions. And one of the 3 days will be dedicated to hands-on tractography and analysis of the tracts with the most advanced free software. We will have with us Lorenzo Bello from Milan and Kostas Hadjipanagis from the University of Pittsburgh as keynote lecturers. You can scan this barcode here or contact me and come visit us during the most beautiful time of year in Toronto. September is very beautiful. And I would like to thank you very much once again.
Okay, Ahmed.
Abdurrahman?
Okay. Thank you to Prof. Aristoteles Kalibas for their excellent contributions. I have some questions. How do patient outcomes compare between a conservative versus surgical treatment approach?
So sorry, Abdel, I didn't get the last piece of the question. How do outcomes of patient compared when which two things? I didn't get that. Can you repeat?
I texted the question to you.
How
Doc.
patient,
I texted the question. Do you see it?
how do patient outcomes compare conservative versus surgical treatment approach?
Again, there might be a glitch there.
I wrote the question to you, Dr. Kalavas, in your chat. Do you see it in your chat?
Okay.
Syed Al-Mahdi asked the question.
Yeah. So PMD change, I see PMD change both overall survival and progressive-free survival, this question?
Yes.
Okay, so PMD for sure changes the overall survival. That's for sure. The progressive-free survival, it changes in one of 1/3 for sure, because at presentation patients become symptomatic in 1/3 of these cases. But there is a need for additional treatments with PMD, so it also changes in most instances progressive-free survival as well. And I got the question of Abdul as well.
Okay.
How do outcomes compare between conservative versus surgical treatment approaches? I would like to clarify that for pachymeningeal failure, there's no surgical treatment. So when we diagnose pachymeningeal failure, we know that surgery is not the answer. We don't perform surgery for pachymeningeal failure. Going one step back, and with the data I showed, one can infer that this type of failure is only seen in post-operative patients. Okay, it's very rare, even non-existent in patients who received radiation alone. This is only it is a neurosurgical entity, and this is only in the post-operative setting.
Very good. Okay, Dr. Shoulder, do you want to comment on what Dr. Kalibas said? Dr. Shoulder, you there?
Yes, I am.
Okay.
And first of all, I'd like to compliment Dr. Kalibas on a really fantastic, thorough, scientific, thoughtful presentation, certainly in terms of content, but also format and style. And I'd like to reinforce his comments about the importance of en-bloc resection of metastatic tumors. It makes common sense, but there's also data that's accumulated over years, published data that clearly shows that the risk of any kind of intracranial spread, lepto or pachymeningeal, is diminished when one can do an en-bloc resection. And of course, also, Dr. Kalibas, as you said, you can't always do that, but it should remain the goal whenever possible. And you alluded to the idea of a margin with radiosurgery targeting. Certainly in the post-operative setting, the Solomon paper you alluded to, the guidelines paper, which is really an expert opinion paper, but I've got nothing at all against expert opinion. The consensus in that paper was to include the surgical tract for SRS in patients in whom the tumors were subcortical, and they're in essence always subcortical. The only question is how deep that is, and to be even quite generous with that targeting. And that certainly will decrease the risk of leptomeningeal, and I don't have any data myself, and I'm not aware of other data that shows that it'll reduce pachymeningeal disease, but it stands to reason, and I think that should be practice. Years ago, when we did our own retrospective review of our LINAC SRS, for all in the postoperative setting after metastasis resection, we found that hypofractionation yielded better tumor control than single fraction, and we didn't believe it, so we kind of ignored it. Then there was another paper that came out from South Korea that showed that hypofractionated SRS gave better control in general for metastatic tumors. And we had started our Gamma Knife program by then, and since then have accumulated data, now have published that indeed there is better control with hypofractionated SRS, as counterintuitive as that may be, and that applies whether it's in the neoadjuvant setting, standalone therapy, or adjuvant setting. So I think that was also a very important point to address. Dr. Kalibas, I have a question for you. Difference between lepto and pachymeningeal disease may be that the dural-based tumors, the nodules, are in essence outside the blood-brain barrier. Are they therefore more amenable? Do we think they might be more amenable to systemic treatments, in particular to immune therapy? And do you have any data regarding the use of immune checkpoint inhibition therapies or so-called targeted therapies, tyrosine kinase inhibitor treatment of pachymeningeal disease?
Thank you very much, Dr. Shoulder. First of all, thank you for your kind words. Second, to answer your questions, I don't have any data on chemotherapy or targeted therapies for pachymeningeal disease. I know there's some interest in some teams exploring this. since it's a new, it's a new entity. We would like to know whether this is the case. I really like the concept, your concept of maybe this is more easily reachable if it's outside the blood-brain barrier with systemic therapy. And I think it's a great avenue for research, actually. And a third point, going back to your very thoughtful and insightful comment about the surgical tract and the margins. Indeed, the paper from Sullivan is expert opinions. That's why I tried to add a little bit of our data to this paper, because we saw that in tumors with preoperative contact, dural contact, increasing the margins, the dural margins of SRS to 6 to 10 can make some difference for PMD. So it was actually a statistically important factor only for patients with dural contact, but it wasn't the same with patients that harbored tumors with dural venous sinuses contact. So we only saw that with dural and pial contact. We did include this variable of covering the surgical tract with SRS in the adjuvant setting in our institutional paper. It didn't yield any statistical importance with regards to the occurrence of PMD, but for sure is a consideration and a variable that one could examine in maybe larger multi-center trials, etc. I have to say that I'm quite hopeful. I really like the data from the neoadjuvant SRS trials, and I'm really hopeful and interested to see what these avenues will bring.
If I can make one more comment about that, yes, I'm a great believer in neoadjuvant SRS for patients with brain metastases. When this was first proposed by Tony Asher, like 11, 12 years ago, he was met with a lot of scorn. And I can admit I was very skeptical also. But after hearing the rationale, thinking about it some more, seeing some of the data, I became a complete convert. In our institution, we're a little limited in our ability to do that because of logistics. Our SRS program is completely outpatient. Patients who need resection of these tumors are almost always admitted already as inpatients, and that creates, as I said, logistic, bureaucratic issues. But we still try to do it whenever we can. But I think one of the reasons for the concerns about local failure in this series and others is that there's a belief that you can use a lower dose, a lower prescription dose on those tumors since you're about to resect them. And in our experience, we don't do that. We give them a full dose like we normally would, usually single dose, sometimes hypofractionated if the situation allows and the tumor we think is too big to treat with a single dose. But we do not lower the dose. And I think, can I say, who cares what I think? It's the data that really matters long term. But I would certainly recommend to anyone who wants to start or expand such a program to use the whatever dose you would use as a standalone, or for that matter, postoperative dose to treat a brain metastasis. If you're going to do it neoadjuvantly, don't think that you'll get away with a lower dose because of the fact that you're going to resect it. The way to avoid radiation necrosis probably in part has to do with also removing the mass, not just using a lower dose before the surgery.
Yes, I have to say that I totally agree with you with your points. What is very realistic, you expressed in very pragmatic settings, is that logistically neoadjuvant SRS is hard, right? And if you have a symptomatic patient from a large brain metastasis, you want to go in and remove the tumor. And then if you are to do a multifraction SRS, this might delay a little bit the surgery. It might be easier in patients who are mildly symptomatic from large brain metastasis. And one variable that I am very interested to see how it will play out, how it will evolve, is if you see now in trials with neoadjuvant SRS, most trials they say do neoadjuvant, operate within the next 48 hours or 72 hours. If there was a bit more relaxation there with regards to the timing, then and we see that this is safe, then the logistic component might be a bit easier because operative time, surgical time, we as surgeons know it best, is very important, and it varies from center to center. Some centers can operate at any time, any time of the day. Other centers are really struggling to find operative time. It depends on so many factors, the financial system behind the healthcare system of the country, etc. It's so multifactorial.
For us, it's mainly an issue of where your device is located. If your Linac or Gamma Knife is in the hospital, if we had that here still, we'd be doing it, I think, pretty much all the time. So anyway, if anyone's planning to cite a new SRS device, let me advise you, if there's any way you could put it in your acute care hospital, that's the way to do it.
You're right.
Dr. Schulder, on a side note, technical point, are you using a smartphone?
I have to. I have a problem with Zoom with our desktops here in the audio. So yes.
No, I'm saying it's excellent. I mean, you were able to get your point across, your opinion, and you weren't hindered by the lack of a laptop or desktop. You just used a smartphone.
Yeah.
It's great to have your voice as part of this, and you weren't hindered by the lack of a laptop or desktop. Thank you.
Well, thank you.
Okay, Abdul, are you there? Hello, I guess he may have stepped away. Okay, do you want to wrap it up, Abdel? Or I'm sorry, any questions from the panelists at all? Or anybody at all? Go ahead.
Does the amount of radiation used in SRS relate to the incidence of Pachymeningeal disease? And is the incidence more with SRS or WBRT?
I don't know if I understood you. Do you want to write it down? It would probably understand if you wrote it down.
I think I got it.
Okay, go ahead. Go ahead.
How does the SRS dose relate to the risk of Pachymeningeal disease? And how does the risk compare with whole brain versus SRS?
Okay, was that it, Abdel? We're being hindered here a little bit. Nathmini, could you understand what Abdel is saying? Nathmini?
Yeah, it's exactly as what Dr. Schulder said. That's what his question
I think
was.
that was a question as well, but I was not sure. Yeah, So in our data, we didn't find that the doses played a role for the SRS because conceptually the damage within brackets has been done during surgery. So let's say you have a tumor and it's deeper than the surface of the brain, and you go in and you remove the tumor. Some tumor cell spillage might happen. And then even if you irradiate the cavity with higher dosage, you don't get the tumor cells that have been disseminated around. On the contrary, the margins, it seems that they do play some role, as we discussed with Dr. Schulder, the margins on the dura. And going to the second part of your question, whether whole brain radiation affects the incident, yes. As you saw, we published that study, the retrospective analysis of our prospective database between whole brain radiation and SRS, and it seems that in whole brain radiation cohort, the incidence of PMD is very low. It's actually 2%. So it does play a role, undoubtedly. But the problems with whole brain radiation is in another level. SRS has been chosen as the preferred method for post-op radiation for other reasons, and mainly it's cognitive decline, horrible cognitive decline with whole brain radiation. And interestingly, in some data, actually, although the distant failure tumors arising remotely from the area that you've radiated with SRS is much higher in SRS versus whole brain radiation, the overall survival either doesn't differ, or in some studies, the overall survival is higher with SRS, which is interesting.
I would urge everyone participating here, if you have any doubts, to leave whole brain radiation for certain specific indications and patients. It should be a small minority of people with metastatic brain disease. As Dr. Kalibas said, we've kind of moved beyond that era, and this is all about neurological preservation and brain function. And radiosurgery has had a major public health impact on people around the world as a result, given the high incidence of metastatic brain disease compared to primary brain tumors. A significant problem in its own right, but metastatic brain tumors are 10 times as numerous as primary tumors. And as I said, it does reach public health level numbers, and we should continue to perfect those treatments, including SRS and medical treatments and surgery when needed, and leave whole brain RT again for selected few indications.
Okay, very good. Any more comments or questions from everybody? We're going to wrap it up. Thank you, Dr. Schulder and Dr. Kalibas, Nethmini, Abdel, and Abdul, he left. We appreciate your time, gentlemen and ladies, and we hope to see you in a couple of weeks.
Thanks.
Okay, thank you.
Thank you.
Bye-bye. Okay, I'm going to stop the recording, and I'm going to